So today we're going to talk about patient anesthetic monitoring. So there are some supplemental pages in your books if you want to read that. You're more than welcome to. We're going to talk about the anesthesia form, the monitoring of anesthesia, and then recovery. The last PowerPoint we kind of talked about getting the patient ready for surgery. Now we're going to talk about what we're going to monitor during surgery, and then the aftercare for our patients as well. The anesthesia form can serve as a legal document and reference for future surgical procedures. So any type of anesthetic that we are going to do for that patient needs to be recorded on this anesthesia form. This should be filled out completely starting with the first pre-medication given. Anything you're doing with anesthesia gets recorded on this sheet here. Information usually is included on the form is the owner's name, the signalment, the weight in either pounds or kilograms, depending on your practice. And then we're going to list the procedures listed in order if more than one. So what they're primarily here for, so like say a neuter, and then they also want vaccines and a nail trim, or we're doing a lump removal or our dew claw removals, things like that. We're going to list them in order at that time. Information usually included on the form as well. Is a physical status scale. So the American Society of Anesthesiologists, or the ASA, there is a scoring guide that we kind of categorize our patients in regards to like how much of a risk these patients are in. They do the same thing with people, like if they have underlying health conditions, they're higher at risk for surgery, or like of having complications during surgery, just as an example. And so we do the same thing for animals as well. Class 1 is minimal risk, so normal, healthy patient with no underlying diseases, so they're going to be just fine. Class 2 is going to be a slight risk, patient with slight to mild systemic disease, i.e. neonatal or geriatric obese patients, so really chunky patients, or full-blown estrus. Their body is busy doing other things instead of and trying to either grow as babies or, trying to maintain things as geriatric. Obese patients are at a higher risk because the anesthesia has a chance of sitting in the body a lot longer with that fat, the way it's getting distributed around. And so we have to be careful of them. Animals in full-blown estrus, a lot of their blood supply is going into making babies. So we have to be careful of that. So they're at a higher risk. Moderate risk are going to be patient with moderate systemic diseases or mild clinical signs. If we have an anemia, if they're anorexic, um, moderate dehydration, moderate fever, these are, we're getting up there in scales of really risky things with our critters. They might not have a great outcome. They might get through it just fine. We just have to be careful of that. Class 4 are going to be high risk, so patients with pre-existing systemic disease or severe disturbances. So like severe dehydration, shock, high fever, heart, or pulmonary disease. Anything with a heart condition or a pulmonary problem is going to be in a higher risk because those are kind of your most important organs right there in order to survive an anesthetic procedure, um, besides liver and kidneys. And then class 5 is going to be your grave risk. So this is a patient with life-threatening systemic disease, would not survive without surgery. So like they are bleeding out to death, or they need to, they're in such severe kidney failure or liver failure, but they need this surgery in order to save their life. They would be a class 5. Information also included could be pre-anesthetic drugs. So we're going to list all of the drugs that we give pre-anesthetically to our patients. Anesthetic induction agents. Make sure when we list both of these drugs on here, we give the drug name and the drug dose in milligrams, because if we put a volume, that's not equating to how much the patient's actually getting. 2 milliliters could be an overdose for a small patient, but it might not be, it might be underdosing for a large patient. So it just depends on how strong that drug is. So that's why we always include milligrams. We're also going to include the breathing circuit if we're going to use a non-rebreather or rebreather, endotracheal tube, depending on what size we're going to use, IV catheter size and location where we're going to place that catheter, intraoperative values, so our monitoring numbers, which we'll talk about, and then postoperative values, which is our recovery monitoring as well. When it comes to patient monitoring, constant monitoring allows the assistant to make appropriate adjustments in anesthesia. The patient is getting too light or too deep under anesthesia. By watching these parameters, we can notice almost immediately that our patient is either too light or too deep under anesthesia. We can also tell when a patient is receiving a painful stimulus. So, like, say they're removing like bone fragments, or we're strumming on the ovarian suspensory ligament. That's the most painful procedure of a SPAY. We can see that change in their vitals. Physiological response to drugs as well. Some of our drugs cause, like our opioids, cause severe respiratory depression. So with that monitoring, we knowing what medications that they're on, we are able to adjust our monitoring and our anesthetic gas um, accordingly to that patient's needs. Parameters should be measured every 5 minutes while under anesthesia, but always observed. Even if you're like, okay, every 5 minutes and you're now waiting for your next 5 minute cycle, you are always still constantly watching the patient. Your eyes don't come off the patient. You're always watching. You can watch surgery at the same time. You want to be very diligent because things can happen in a matter of minutes with these critters under anesthesia if we're not paying attention. Our parameters that we're going to check are TPR. So we're going to check heart rate and rhythm, respiratory rate and rhythm, capillary refill time, which is CRT, mucous membranes. We're going to look at their color, and we're also going to take their temperature, all under anesthesia. So ways we can take their heart rate, or beats per minute, BPM. We'll use a stethoscope to just put on their heart. We will use their pulse, the femoral pulse, which is on the inside of the back leg. The carpal pulse is on the wrist um, of their front legs. And then there's also the lingual pulse. We can take it under the tongue. We can feel the heart through the chest wall. We can't feel it for rhythm, but we can feel it for counting beats. But we can't see if they're throwing like weird arrhythmias or anything. We can also use an esophageal stethoscope. This is a really cool stethoscope that's over here. This goes in down the esophagus, and it sits right next to the heart, and so you can hear their heartbeat very, very strongly, which is really cool. Heart rate effects under anesthesia is going to be slower than an awake animal. You do need to understand these parameters here. If they're going to be lower or higher, you need to alert doctors between dogs and cats. So dogs, this is their normal heart rate. If it's lower than these, then we need to, or higher than these, we need to contact a doctor. Sometimes our smaller dogs, it's going to be a higher heart rate. With our cats, they have usually a high heart rate. Again, we want to make sure we notify a doctor if it's too high or too low is there. Anesthetic drugs can cause cardiac depression effects so that we can lower the heart rates too much. They can also cause arrhythmias. Arrhythmias cause the heart to pump ineffectively, which leads to poor perfusion, poor oxygen delivery to the tissues, buildup of waste products in the body tissues as well. So we have to be very, very careful of that. Some animals already have a natural arrhythmia, like a sinus arrhythmia. That is when they inhale, their heart beats faster. When they exhale, their heart beats slower. And then with our drugs that we give them, we can kind of make that worse. And so we have to be careful of that as well. Hypothermia can cause cardiac depressant effects. So if they're too cold, their heart's getting too cold and it can't pump the blood through the body enough. Shock and pain cause an increase in heart rate. If they feel painful stimulus, you'll see their heart rate spike up. And a pulse deficit is an arrhythmia, so it means also poor tissue perfusion. This means that if we're listening to their heart, like say with their stethoscope, and then we're feeling back on their femoral pulse, that means that the blood, and if the pulse doesn't match the heart rhythm, or excuse me, heart rate, then they have a pulse deficit. That means the blood is not circulating around the body adequately enough, and it's not getting to the tissues adequately enough either. Respiratory rate, RPM or BPM. Be careful using BPM because BPM, we just learned that we use that as beats per minute. BPM for respiration can mean breaths per minute. We usually do RPMs for respirations per minute for our respiration rate. We can watch the chest move, inhalation and exhale, that's 1. If they do it again, that's 2. We can watch the reservoir bag inflate and deflate. When they inflate, when it deflates, it's 1. When it expands, it's not 1. when the band, when, hello. So if their bag is constricting, they are inhaling, and if the bag is inflating and getting round, then they are exhaling. There we go. We can also count condensation in the ET tube, and we can count respirations per minute with just using a good old-fashioned stethoscope. We can watch the flutter valves as well on the anesthesia machine. We have to be a little bit careful with that because sometimes they flutter a little bit too much, and it's not really, really accurate. Um, we also need to make sure that we consider temperature. We can use a rectal thermometer, just like how we normally temp dogs, dogs or cats or other animals. We can also use a rectal probe with a monitor that it might be attached to a multi-parameter window, like you guys have seen before in a previous assignment. We can just stick that up their bum. I've also seen esophageal thermometers as well that we just stick down their esophagus, like the esophageal stethoscope. Um, Respiratory effects under anesthesia, usually slower than awake animals. Canines and felines have very similar respiration rates, so we want to alert if they're either too high or too low as well. Um, Abnormal respiratory rates and rhythms that we can see are shallow, decreased respirations, breath holding, agonal breathing is kind of where they are struggling to breathe. Apnea is the lack of breathing, so loss of breath. And then apnoistic breathing, this is kind of like a gasping. So they're trying to breathe that in. That is not good as well. They're kind of suffocating some, so we have to address that quickly. With their body temperature, again, they're going to be about the same height, same temperature. If it's too high, too low, we need to notify immediately. Majority of our animals will become hypothermic under anesthesia. A few may become hyperthermic. They have there are conditions that some of our drugs can cause that causes malignant hyperthermia. So these animals on the surgery table will actually bump up to 103 to 104 degree fevers as a drug reaction. So we have to be very careful with that. I've seen it happen before. It's pretty scary. We got to cool them down really quick, and we have to wake them up from anesthesia. Factors that lead to hypothermia, like how majority of patients will go. Anesthetic drugs make them colder because they can't thermoregulate. Scrubbing, think about we're using water to or soapy fluids to clean off that animal. Room temperature fluids are not great either. If you've ever had room temperature fluids, it can cause it's really, really cold because our animals are going to run warmer than room temperature. Gas is cold when it's also inhaled, and so that's why we use those F circuits to try to warm the air as they inhale it. And the body cavity exposed, open, exposing internal organs. So if they're doing abdominal procedures and like all their organs exposed to the air, that is also going to release a lot of body heat naturally as well. When checking our mucous membranes, we're going to look at them as a general indicator of tissue perfusion. So that means that the tissues are getting adequate blood flow to them. Pale mucous membranes are going to be poor tissue perfusion, anemia, or hypothermic. So these are going to be a very light pink color. Good mucous membrane color is what we call bubblegum pink. So if you just think of that. Hyperemic mucous membranes, so these are going to be red. This can indicate sepsis, so a systemic infection. Cyanotic mucous membranes means poor oxygen circulation, so these are going to be blue looking, if not purplish. The biggest thing is to not look at pigmented mucous membranes, so like animals that have a lot of like black pigment in their mouth, you can't look at that correctly. You need to look at the pink part. So when you'll push on their mucous membranes and it'll go white for a second, and then all the blood will come rushing back in. Excuse me, that's for capillary refill time. We're just looking at the color at this point for our mucous membrane color. When we are blanching the mucous membranes, that is looking for the CRT. So the capillary refill time and we're going to alert if it is greater than 2 seconds. A prolonged capillary refill time indicates low arterial blood pressure or peripheral vasoconstriction. So that means they have low blood pressure and they're not getting enough blood flow to uh, peripheral tissues and things like that. And so we don't press hard because that falsely prolongs the capillary refill time. So we just press firmly, really quick, so that way it blanches white on the mucous membranes, and then we release our finger quickly and count how fast it takes for the blood to fill back on that spot that we pushed all the blood out of. Pulse and blood pressure. Pulse strength is a general indicator of blood pressure. If it's difficult to palpate that pulse, then they probably have low blood pressure. That means it's not getting around very well. Strong and bounding, so you can feel the boom, boom, boom with your fingers, indicates high blood pressure. Mean arterial pressure, or MEP, can also be measured with a Doppler. We will alert if that falls below 60 millimeters of mercury. We will alert our veterinarian. How we assess depth of anesthesia: eye position. So central is very light planes of anesthesia. Rotated ventrally is a surgical plane of anesthesia. Only whites visible or central can mean deep anesthesia. So always be careful of that. That whites visible or central can mean one or both, one or two things, either light or too deep. So just be aware of that. We can't always rely on that eye position, as noted before, and so some other ways that we can check for level of consciousness in our patient: jaw tone, loss of jaw tone as anesthetized. So this deeper they are, the less jaw tone they have. So like if you open their jaw, there's no resistance there. The palpebral reflex or the blink reflex should be absent or minimal in surgical plane of anesthesia. So if you take your finger and poke the corner of your eyelid, your reflex should just naturally blink because you're like, oh my God, I don't want to stick my finger in the eye. And so that's going to tell us the level of consciousness of that patient. The pedal reflex or the toe pinch, loss of reflex to pull foot away from painful stimulus. So we actually pinch in between their toes, the little webbing area. The auricle reflex or the ear flick. Ear twitches or flicks when lightly touched or tickled. Sometimes we'll blow on the ear a little bit to help stimulate them. The laryngeal reflex or the swallow reflex. This is discontinued swallowing reflex when material is placed close to the trachea. So when we intubate our patients, and the deeper they are, they lose this reflex. And we'll talk about this when we were covering that why this is super important, that they have their swallowing reflex before we pull their tube out. A well-trained, educated alert technician or assistant is the best monitoring device. The electronic monitoring devices are helpful tools, but should never be relied on for 100% accuracy. Machines break all the time. Yes, there are human errors every once in a while as well, but we always just use the monitoring equipment as a double check system. You are in charge of that patient. Monitoring that patient, you are that patient's lifeline and your first defense on making sure that it does successful under surgery. So just be aware of that. The doctor and technicians are going to be there as well, but if you're the one who's in charge of monitoring that patient, you have to make sure that you are on it at all times. You can't always rely on on monitoring devices to give you accurate information. So just be aware of that. Our monitoring devices: the pulse oximeter measures the level of oxygen saturation in red blood cells, percent of the available hemoglobin saturated with oxygen. So pulse oximeter is measured in percent. It also can measure a pulse rate. Uses red light and infrared light to measure arterial blood flow. Primarily, we're looking at it for the oxygen saturation. The pulse rate is just a secondary, so just be aware of that. There are various sensors available: the lingual sensor, the reflectance probe, and the C-clamp. So make sure you do know where these guys all attach. For the most part, we do stick them on the tongue. Sometimes we'll stick it up the bum. So here's an example of a pulse oximeter. Here are the 3 different clip types. If you've ever gone to like a doctor's office or a clinic where they just put that tiny little electronical device on your finger, that is also a pulse oximeter. Sometimes our pulse oximeter is in combination with other monitors as well. So normal values, you do need to know the normal values. 95% to 100% is normal. If dropping below 95%, 5% indicates inadequate oxygen to the brain. What to do at that point? You are going to alert a veterinarian. You're going to check that probe placement. Did it slip off? Especially when we're doing like dentistry, these guys like to fall off all the time. So if you're like, oh, that's a weird number, always make sure that your probe placement is on there correctly. Wet tongue with tap water. That sometimes that contact helps a little bit. We're going to check oxygen flow and decrease vaporizer settings so that way they get more oxygen and less gas to help kind of boost that oxygen saturation there. The capnograph, this measures the level of carbon dioxide during exhalation. So this also is in conjunction with end-tidal CO2. This can also secondary measure respiration rate. The sensor attached between the breathing circuit and the endotracheal tube. That's where it must be placed. The normal values are going to be 35 to 45 millimeters of mercury. So that's our parameters right there. Low means increased respiration, light anesthesia, pain, hypoxia, or overventilation. Decreased end-tidal CO2 means decreased respiration rate, exhausted soda lime, or a kinked ET tube. So that means they're not pushing out enough carbon dioxide. So that means it's staying in their system. So I know it sounds opposite. You're like low, they have increased respiration, and you're like high, it has decreased respiration. So it's kind of backwards on there. So just be aware of that. So with our capnograph, elevated end-tidal CO2 means that the patient is rebreathing exhaled carbon dioxide instead of oxygen. So that means they're not getting enough oxygen flow into their body. And so things that we can do to fix that is we're going to check our anesthesia machine. We're going to check that our scavenger is absorbing correctly, our CO2 absorber is correct, is circulating and filtering out that carbon dioxide properly. And we're also going to check our pop-off valve that it's not turned off and that they're like suffocating. And so we are going to also ventilate and try to ventilate them with pure oxygen at this time. We'll probably turn our anesthetic gas off as well. Our non-invasive blood pressure monitor, or NIBP, this uses an appropriately sized cuff that inflates to measure the blood pressure. The cuff width must be 40% of the circumference of the limb used. So that way, because if we have too big of a cuff here or too small of a cuff, it will give inaccurate readings. The too big of a cuff, it won't constrict the blood vessels enough, or if it's too small, it'll just explode right off. And so the cuff length should be secured around the limb used. So usually we use like a back leg or a front leg. We don't use it on the same leg that has an IV catheter in it because that would be kind of counterproductive if we're trying to administer fluids. Our values that we're going to use are systolic, diastolic, and mean, just like within people. And we're going to alert if that mean is less than 60 millimeters of mercury. Here's an example of that. So this is right here on how we measure our blood pressure cuff for our patient. So again, that's about that 40% width of the circumference of the leg. And so then this is how we attach it here as well. The electrocardiogram, or ECG, this measures the heart rate and wave formations of electrical impulses of heartbeats. This allows for monitoring of the rhythm of heart and catch changes in the beating of a heart. And so we can actually see how that heart is pumping and contracting on a measurement scale. So these are called like QRS waves. We're not going to go way into like what a QRS wave is and how like the contraction, the systolic and diastolic work to make these waves. That's more for the tech program. What you do need to know is how we attach the leads to the patient. White is in the right axillary, so the right armpit. Black is going to be the left axillary. Red is going to be in the left rear, and then green is going to be in the right rear. Green is the one that we don't always have I've worked in plenty of facilities that have not had a green lead before, so just be aware of that. So if I had my little stick guy here, dink, dink. So my green lead would go down. If this was the patient's right and this was their left, my green lead's going to go down right here, attached in the inguinal area. My white lead, which I will use, come on, black for this one. Nope, can't use black, just kidding. I'll use purple for this. I will put it in the right. So the little reminder thing that we always were taught is white on right and then smoke over fire. And so the black is on the left side here, and then red, which I will simulate with orange on this guy. So our red guy is going to be in the left inguinal region here. So this is where we would attach our leads, and then that would be attached to the monitor. So you do need to know all the different placements of these guys, so just be aware of that. We do, after we attach those leads, use alcohol for good transduction because they're electrical signals, and so in order for the monitor to read them, they need to have this transduction solution, and we just put alcohol in those little leads there. This is a blurry picture. So you can see this is where our monitors are hooked up right there, right there, and there's one down here. Just like that. Again, not everybody has that fourth lead, so just be aware of that. So we've monitored surgery, and now our patient is coming out of surgery. So this is post-operative monitoring. So when the gas anesthesia is discontinued, the patient remains on oxygen for several minutes. This helps flush gas anesthesia from the lungs for faster recovery and provides supplemental oxygen until the patient respirations are within normal limits. Again, we're trying to push all that gas out of their system so that way they can breathe in a normal manner. At this time, we're going to detach monitoring equipment, so our ECG, SpO2, and our end-tidal CO2. We're going to continue monitoring at least the heart rate, mucous membranes, capillary refill time, and temp manually at this point. And we're always going to have a hand on the patient as they wake up because this can be part of our, some of the most dangerous processes is recovering our patient after anesthesia. Before we extubate, so before we take out that endotracheal tube, we're always going to deflate the cuff. If you don't deflate that cuff, if we think about it is a balloon, it's like it's a square peg going through a round hole. So just be aware of that. We don't want to, we can actually break the trachea, essentially, if we don't deflate the cuff, the little balloon thing. We're going to untie rolled gauze from around the head, so that way it's not attached to them. We're going to watch for that swallowing reflex to return, and when the patient has swallowed 3 times in a row, not like just 3 random swallows that like they swallowed 3 minutes later, swallow, 5 minutes later, swallow. No, it needs to be 3 consecutive times in a row at minimum in order to pull this ET tube out. Then it's okay to pull it out. If the patient wakes up rapidly and is coughing or chewing, then we pull it out as quick as possible. With our brachycephalic breed, so these are our squish face guys like our pugs and our shih tzus, we're going to leave that tube until they're sitting up completely. They need to be literally sitting up and about to chew the tube in half in order for us to extubate them, because these guys, as soon as they relax back down, their soft palate falls down over their trachea and they are unable to breathe and they can suffocate and die. We have to be very careful of that. With that swallowing reflex, we want to make sure that they're swallowing, because if for some reason any gastric contents come up, like they regurgitate or they vomit for any reason, if they're not swallowing it back down, that stuff has a chance of going into the trachea and down into the lungs and can be cause aspiration pneumonia, so it would be really, really bad. When we're covering our patients, we're going to keep them warm during recovery until the temperature is about greater than 99 degrees Fahrenheit. Some patients experience what's called a rough recovery, so this is where it's really dangerous, termed as dysphoria. They are not in pain when the anesthetic drugs wear off. We need to keep that patient restrained and padded as much as possible, because these guys will start thrashing over their place because they don't know where they are. They know something is happening, but they're freaking out. And so don't put your hands or your face near the patient's mouth. I've seen people almost get bit in the face. I can talk from experience. My dog, when he came off the surgery table, he was fine. He was recovering in his kennel. I had my hand on his neck and I was extubating him. He immediately woke up and he about nailed me right in the face. And I was sitting back and I wasn't like even, like had my head near him or anything. And so these animals are not doing it out of aggression. They're doing it out of reflex because they're like, oh my gosh, I don't know what's happening. I need to try to stand. I'm freaking out, and they're scared and they're trying to lash out. So you have to be very, very careful. So this is a very dangerous period for these critters. And that's that.